How's everyone out at home?
Okay.
Good, excellent. Hello to everyone here in the center. Good to see you all. Sorry about the change of plan, but I was supposed to be in Davis, and then they called me in at 10:30 to Sacramento. I figured out either I drive and talk to you guys, or I just drop by and talk to you guys. So I figure I'll drop by. But anyway, I don't have any specific presentation ready for today. I would make an important commentary for people. Puerto Rico is not an island full of garbage. Just for the record, like I said that straight. I was just there last week. It was pretty clean, actually. So
Why
anyway,
getting that reputation?
I don't know.
Uh-oh.
I don't. Oh, you haven't heard about this?
No. What's
Linda's in the dark. Somebody can tell her later.
I'm in the dark too.
I don't want to spend our time talking about politics.
Okay.
Oh, okay.
It was a political thing.
Oh,
Well, I have one political question.
Yes, it's not true.
In heart patients, not just politics, but all the stuff that's going on and then on top of it.
It's actually a very interesting question to which I have a long-winded answer. So are you ready? In fact, it's because it's 10 minutes of a presentation I make. So since the 1950s, that's last century, cardiovascular death is being kind of in the, actually not 50s, more kind of closer between 60s and 70s. Cardiovascular death started coming down. It actually was on the way up until then. And it started coming down in the 60s, 70s. And in part, we think it was because we started learning how to prevent things. And we started talking about anti-smoking campaigns and exercise campaigns. And by the 1980s and 90s, we started talking about the cholesterol being such a big important thing. And so we got very good drugs for cholesterol, very good drugs for blood pressure control, all of these which are factors of cardiovascular disease. And so the mortality from cardiovascular disease keeps going down into the 2010, 2014. And right at between 2010 and 2014, it actually stops going down. And it actually in the last 5 or 6 years is going back up. And so our medications for blood pressure are better. Our medications for cholesterol are better than they ever were. There's less people smoking today, at least in the United States, than there were back in the 70s, 80s, and 90s. So we clearly have something else happening to us that it's not attributable to those, because those things only got better at reducing those risks. And suddenly we're not going down, it's going up. Now, some people think the pandemic has something to do with this. And it is true, the pandemic has something to do, but when you correct for the numbers of the pandemic, they still an uptick. And so that's what we call the missing risk. So there's something out there risking us and increasing our risk of having a cardiovascular event that we're missing it. We don't know what it is yet, clearly. We have some ideas, and I'll give you a couple of them. And so it's not genetics, because genes don't change in such a little amount of time. So it's more something that's happening to us or something we're exposed to. And so until about a year or two ago, I was saying it was stress, stress, stress. Then it came loneliness, and loneliness was a call that the Surgeon General actually pointed out how powerful loneliness is in affecting your cardiovascular health. And then within the last year, I learned that microplastics are the other thing that we don't think too much about, that we're exposed in the environment. There's also pollution like exhaust pollution, fire pollution. So I think all of these things are part of the missing risk. So stress is one of them. Microparticles, microplastic particles, air pollution, loneliness. These are all things that are exposure, environmental things that we're exposed to that are affecting us cardiovascularly. So those things are probably winning out the battle against, the blood pressure, and the smoking and the cholesterol is no longer the most important thing. They're still very important, but they're not anymore the most important thing. There are these other things that are now offsetting the value of controlling those that we need to start thinking about. Now, where do you fit politics in there? I'm going to leave it up to you. But stress is clearly, and stress is usually measured by depression and anxiety. And many of the studies that point at this is depression, anxiety, and then loneliness is thought to be also a trigger of stress as well.
Are you gonna make a comment, Ron?
Yeah, medication side effects are an annoyance, but they're not necessarily a trigger of worse outcomes. Then, in fact, that's what all the clinical trials are testing for. In the clinical trials, they give people a sugar pill and the medicine, and then the analysis they do is, was there more benefit than the actual adversity that they had? And that ratio has to be pretty good before the FDA approves it. So if it's just about this much badness and this little goodness, here the FDA is saying, not sure we want to do that. They usually want this to be really far away. Now, obviously, the FDA approved drugs that have that very narrow when there's nothing else. But if there's something else better, the FDA say yours is not good enough because there's other stuff that's better. That's the kind of stuff they do. So even though, yes, some people have adverse reactions, some people have side effects to medicines, they're usually, when you look at it on a population level, usually that side effect or that adverse event is not greater than the benefit of the medicine. When we see that, and this does happen, some drugs, it happens after their market, they have that, then the FDA pulls them, or they put us, give us a what's called a black box warning, like, don't do this, because when you do that, you get a lot of adverse events. And so that gets a black box warning for us. And so we avoid them prescribing it either to that kind of person or to that in that kind of situation to avoid the side effects at that point. So yes.
I know in my own life that a wonderful psychiatrist that I have had told me that it would be best to stay away from the news. And that he does. And it was really hard to do, and it still is. But I can notice a difference on a day when I'm sucked into YouTube or the television. And I'm so sorry I did that because everything in me is different. It's good.
Yeah.
And when I'm away from it for even for a day, it's like, wow, this is really not. I guess I should know what's going on. It doesn't make any difference, and it's
Yeah.
I can tell it.
You know, that's very real. And I hear the story all the time. And I actually advise certain people to just unplug, disconnect things, and just tone it down a little bit. It's just too much. It's just chronic, becomes chronic stress. It's not just in a rare occasion there's something bad happening on the news, and then the rest of the time things are just kind of, and then boom, it's kind of like boom up there. So
Marianne wants to say something.
so yeah, so it's important to recognize that sometimes you got to turn off the stress source, so your body gets to recover and then come back, then challenge the next time. So yeah. Yes, somebody at home. Yes,
What's going on in Puerto Rico?
Yeah, I just wanted to I wanted to second that because I agree with that, but I also was listening to your the up and down scale, and it seemed to go up again
that's the up and down.
in corresponding to what I see as the increasing violence of language in the media. And that's my personal experience. The more antagonistic the language in the news, the more I stress out. So that's what I'm tagging your statistic to.
Why is there more bad language?
No, in the news, in the political news is the increasing, I don't know if violence of language is the right word, but the antagonism that I see in politics in the recent years stresses me out more than the news ever did. So
Yeah,
that's my correlation to your statistic.
yeah, that is in part true. The way we go about with each other is very different. I can see it. I work with teens and at UC Davis and in other community programs, and the interactions are very different. And we have to now make effort to make sure that we don't let the interactions go down in the wrong path. Where before, it was hard to go that way because everybody was kind of buffering it or buffering those moments. Now it's almost as if none of us have to buffer anymore and just go
Yeah.
down that antagonistic, forceful, somewhat not tolerant, gentle kind of. I mean, I'm seeking words here to kind of convey a thought. It's not easy, but yeah, I mean, it's definitely, I can tell you that the work interactions are definitely different than 5-10 years ago. There's a sense, and now we're going to talk politics. I'm sorry to say that. And I'm happy to stop, if people think this is inappropriate, but I think the sense that we're all in the same thing, the same society, the same community is being actually hijacked from us. And to self-promoting ideas or ideals of some. And so certain groups are promoting the idea that we're going to win over others. And we've always had this, win at the baseball game, we're going to win at the casino, we're going to win in the election, this year. It's always been part of the society, but we've gone to a level now where the losing of whatever it is intolerable. And so then the need to win becomes such a existentialist thing. And now we're willing to lie and step on each other and spit on each other and, break things and, call people names and become intolerant of each other. And unfortunately, unless we put the brakes on this a little bit, there's some trouble coming down the pike with this, because history is full of this. History is full of this cycle. This is a repetitive cycle. This is not the first time it's happened in history and in this society. So if we don't kind of take a step back and think about, okay, well, we need to slow down this because, continue this escalation, if you will, only going to bring more stress. And sooner or later, people are going to be taking more, action against each other, because that's what we have spent time talking now. It's like, we're going to win this and we're not going to accept the losing. And well, to be winners, we got to have some losers. It just doesn't work any other way. It's always been that way. It's not like a new thing. And people act as if they've never lost before and they can never lose ever again. And now I'm going to just go and beat something up or something. I don't know. Or call Puerto Rico an island full of trash, or whatever. What's the thing? Yeah. Yeah, absolutely. Don't want to end it on that. So
Well,
to pull out of our misery.
It is about stress, though. I mean, that's a big source of stress. I think, at least for me, I feel separated from my community.
Yeah.
And I don't see that as necessarily political. It's just that that's how I experience the current dialogue, is separation.
But don't you think technology also separates us or has something to do with that too? When we're talking about loneliness and separation, when you'd rather, this is just an observation, when you'd rather be remote all the time and not close up, I mean, as it applies to loneliness, and then loneliness leads to, I mean, it's a contributing to certain death, certain deaths that occur. I always wondered, the way technology is going with how we communicate and the kinds of communication you mentioned, these polarizing points of view. People feel like they can get away with that. The anger the vitriol is so horrible online because, they're not in person. They're just, they're remote and they're sending this vitriol out into the electronic ether or whatever. I just wonder how much that has to do with my life. I mean, technology is great, but on the other hand, I guess maybe it's a double-edged sword. I don't know. Do you see any of that, or am I just like?
No,
I just
you can't even talk to somebody when you order your lunch at that food place.
Yeah.
Mm.
Yeah. No,
I just wonder, I'm just.
Yeah, I always, I only curse in two places. One is on my computer when I'm trying to access technology and it's not working for me.
You're shouting at
I shout at the thing. I just curse at it. And then the other one is when I'm driving. So if you see me curse, I don't curse like that at home or at work or anywhere else. But boy, somehow I feel loose. Yeah.
Depends on what you're using social media for, right? And how, so if you're going on there and you see it as a way to stay connected with people, you're using that to build ties with people. But if you're looking at it in a sense that, oh, this is what I'm missing out on, and it's replacing actual moments of like coming together with people. It's not on the phone and stuff like that can actually help build connections, and it can't help, but it just depends on how you see it. Is this the only way I'm interacting with the world? Is it making me separate from everything else versus making me help supplementing that interaction?
No, that's a great point.
Yeah.
Yeah, yeah. It's a great point. It's technology is supposed to, and this is where I wanted to get to work for us. It's supposed to help us build what we want to build, relationships. So if technology is helping us build relationships, communicate better, and fulfill, knowledge and the quest for happiness and all that is great. But when technology is isolating us, keeping us away from human interactions, we're social entities. So we need human interaction. We need a hug every so often. We need a handshake every so often. So when technology is actually keeping us away from that, then it's not working for us. It's working on its own or working even against us. So we have to evaluate it. It's, I think, what you were saying, to make sure that it is serving the greater purpose that we have. So.
I can share an example of where it's kind of working. I have a sister that moved to New Mexico in a really isolated area. And I'm so proud of her because she's a big knitter, and she is an artist with her knitting. And she's recently, in the last 6 months, found this Zoom group, which is some guy in, I think, in the Bay Area that hosts this monthly or weekly Zoom session where all these knitters join him, these fabulous knitters. A lot of them are men, and they basically talk about knitting and they talk about yarn and they show off their projects. And I've watched a couple of them because they report it, and this has been great for her because now she's always makes these amazing things, and she's sharing them with other people that she's never met before that are in Spain and the Midwest. It's just fascinating to hear her, and she's so proud of herself because she's not a super tech savvy kind of person, and so that she gets on this Zoom meeting, shows herself, shows off her knitting. I'm just really proud of her.
We have one of those in my parish, and it's for knitters, and there's another day that it's for quilters.
Yeah.
Yeah.
In person.
But it's in person. Yeah, hers is all on Zoom. He's
So far away.
yeah.
I'll mention that we're trying to use technology to better people and better health. And so there's a study that we're going to start doing with cardiac rehab patients after they finish cardiac rehab. And we're going to use technology trying to keep them engaged, actually, not to keep them away. Although they will be able to do things at home through the program, the idea actually is to connect them with technology. So when they are doing things at home, are not just isolated, but rather connecting, even though we would be supporting them to do it at home. We also want to support for the social connection. So we'll see. It's an interesting approach, using what technology feels in the front is to separate people, but actually to connect people. Kind of to your point, it's how you use it could actually be very powerful, very helpful. So. Yes.
I have another question, different.
I just want to make sure before you ask another question, anybody from home? I haven't left anyone from home that I saw a hand up and a hand went down while we were talking. I just want to make sure I don't ignore you completely. So, okay.
Can you explain the procedure cardio stress test to me and why the cardiologist has to be there?
Oh, the latter is easier to answer. The cardiologist is there to make sure that something bad happens to you, they can blame them.
No, I think it's
That was a joke. No, and the point is, if there was to be an adverse event, something happens at the moment, the cardiologist can recognize it, stop the test, and address it. I could send people for this all the time, and it is true. I mean, I don't think I've ever seen somebody have a cardiac arrest under exercise testing, even though we're constantly testing people who are sick. I've never really seen one. We do have people who have arrhythmias and low blood pressure and get dizzy and lightheaded, and so we need to stop the test, make the decision to stop the test before something actually happens. So usually that decision relies on the cardiologist, but it could be any doctor. It doesn't have to be a cardiologist. It could be an internist. It could be a ER doctor. It could be a radiologist. It doesn't have to be a cardiologist. Any doctor with 2 hours of review of the material can actually supervise the test because it's very safe. They just rarely have these, moments where you don't feel well, or the blood pressure is not good, or the EKG looks a little funny, and that the answer always is stop the test. And usually that stops whatever the problem is. So
I think they can bill you more too if the doctor.
probably.
For me, that's
Yeah.
really one reason that he's there.
Yeah.
Me.
Yeah. Yes.
Heart failure with preserved ejection fraction. So my understanding is there's really no medication that needs that have been studied or exercise, diet, or single on lifestyle intervention. So what people tend to work on is the comorbidity. Now, I'm just going to assume that working on those comorbidities don't hurt anything with respect to heart failure. Do we know that for sure?
Yeah, that's a great question. So the question is about heart failure, preserved ejection fraction, which, although it feels like it's like the new thing around town, it's always been around. We just have recognized it better and give it a name now. The premise of the question is that we don't have any good medicines for it. It actually is changed in the last, I would say, just 12 months. We currently have probably 3 medications we can use. None of them are very good. I mean, they're okay. They're not great. And so we're starting to put people on multiple of these and getting some people feel better with it, but not everyone. And so we still got a lot to learn from this. There is actually a clinical trial going on right now for exercise, cardiac rehab style exercise for people with heart failure, preserved ejection fraction. I don't know the results of it yet because it's still ongoing. And so we would have a direct clinical trial answer to your question when it comes to the exercise portion. The other part of the question was about lifestyle, and how lifestyle affects this, and can lifestyle changes maybe harm? I think if I understood you correctly.
We're only going to work on the comorbidity. Do we know whether that helps?
Yeah.
Thinking we're doing that myself.
Yeah. So the answer to help is yes, it definitely helps. And the more off you are in your comorbidities, the more help it does. Although there may be a point of no return. So if you go long enough with comorbidities like high blood pressure and diabetes and kidney failure and things like that, there may be a moment where more exercise may not make a lot of difference. So, but that's very rare. I very rarely see somebody at that point. And I'm going to make the case in point with one very specific clinical situation happening at UC Davis. So I had a colleague of mine who's a nephrologist, kidney doctor, who said to me, I want to work with people who are about to go into dialysis. So dialysis is what you get if you have had kidney failure, usually for a prolonged period of time, although some people happen very fast, but that's a small number of people. The majority of people have kidney failure for prolonged years, and slowly with diabetes, hypertension, and other comorbidities. And then at some point, the kidney just kind of loses enough ability to clean your urine, to clean your blood of toxins. And then you need to go on dialysis, which is a machine that cleans your blood outside. And, it really changes the way you live your life. And it's life-saving, but it's also life-ruling, kind of determines the way you live your life, because you then need to do this 3 times a week, every week for the rest of your life, usually. So it's a big deal. And so he said to me, well, we want to test exercise and nutrition on these patients that are about to go into dialysis. And I was like, okay, just kind of late, but okay, sure. And so he started his study and we helped him get it started. And a couple, it's been now like 2 or 3 years he started the study, and he came back and said to me, "You don't know what happened to our study." I said, "Well, what happened?" He said, "Well, people don't want to go on dialysis." I said, "Why they don't want to go on that?" These are people who are bound to dialysis, predicted to go within the next 12 months, end up on dialysis usually. He said, "None of them want to go on dialysis." I said, "Why not?" He said, "They all feel great." It's like we keep telling them, you got to go and get your shunt put in and your catheter put in to prepare you for dialysis. They, why would I do that? I feel better than I have felt in years. So now because they feel great, they no longer believe the doctor that they have, and their numbers are fairly similar in the blood test. It's not necessarily like the blood test got better, like they're healed kind of thing. But my God, they feel so much better. They're delaying, they're getting on dialysis. We don't know where this is going to end because he's doing the study. But I was quite pleased to hear that people felt better, because when you have this comorbidity as you approach dialysis, you just don't feel well. You're fatigued, you're short of breath, sometimes you lose your appetite, you just get tired easily. It's just all these lousy kind of feelings. And usually the answer, oh well, let's get you on dialysis sooner, because you feel better from those, because it's the toxins that are building in your body. And these people are just exercising and making community, because it's a group effort, and joining together, and they feel better, so they don't want to go on dialysis. So I think in general it's fair to say that improving on your comorbidities, which usually means improving lifestyle and maybe some medicines, in general makes people feel better. And so whether the conditions changes the direction, it depends, but most of the time people would feel better, and that improves your situation, even though the numbers may not necessarily be as bad. We see all the time. We have a diabetes program in cardiac rehab now at Davis, and in fact, we're writing this up because it's phenomenal how well people are doing with their diabetes when they come to the program. But what really bothers me about this is that people have been abnormal with their diabetes for 15 years. Then they have their cardiac event. Then they come to us, and we work hard. It's a hard program to work with, but we get great success. It's like, well, we had to wait for 15 years of uncontrolled diabetes to have your heart attack before we could actually control your diabetes. So that's the half full of that story is that's great. The half empty part of that story is like, why do we have to wait so long? Let's get on it earlier. And it all starts with the lifestyle. Truly, these comorbidities, lifestyle is at the beginning the best and most powerful thing. So, and the judge is the jury's still out on the HFpEF and the medicines, but we do have some options now that we're starting to use. So.
So can you think of an example of when it would hurt, make it worse? Do you have an example?
What he said, I mean, like, for those people who are talking about, maybe also be on dialysis, who are, it could go either way, it looks like, oh, dang, you would have taken the dialysis.
Yeah, they and as long as they're monitoring with their doctor, they're not harming themselves. When the numbers get really bad and they really, the doctor will say, we cannot wait any longer. But he was saying to me in a casual way, he was saying to me, that time is not arriving soon enough as we expected, otherwise. So he was quite happy that he's seen a benefit to his patients with the intervention that they're doing. So it's a good news. I'm waiting for him to write it up and publish it. But that is what he was explaining to me. An example of when you can go wrong is if you change your diet enough that you actually become malnourished. And I've seen plenty of this, unfortunately, especially when you go from somebody who eats steaks and chicken all the time and then switch completely to plant-based. And now I've taken all that out in a very short, very abrupt way. If it's not done with supervision and support from a dietitian, usually, or somebody who knows better, you can actually reduce so much your calories and your protein content that you start breaking down muscle mass. And now you lose the weight you wanted to lose, but you also start getting fatigue and don't feel as energetic and stuff like that. And it's because you lost too much. And it's an easy solution. You put a little bit more nutrients, a little bit more protein into the diet, and people bounce right back. So I've seen this, and this is part of what we look for in our practice to make sure we don't overdo it. And so that's one scenario where you can actually go overboard. but it's not that you did too much good, it's that you took a good decision, but in the execution, there were limitations of what you were doing. So that's where you need advice and support from licensed providers and physicians and nurses and nutritionists and whatnot. So
Are the new meds for ejection fraction readily available, easily available, covered by insurance and all that stuff?
they are readily available. The cover by insurance is always changing towards the better. I'm not sure that every insurance yet covered them all. I will caution against the one that it's not necessarily quite there yet. There's one medicine that is being used for diabetes, it's used for weight loss as well, and it's been kind of a like a gold rush into the West kind of thing towards a lot of people seeking these drugs for the weight loss. And there's been some shortage of it. And so you may have heard of this in the news. And so the companies realize, wow, we can do it. So every pharmaceutical company out there is trying to put one of these out on the market right now, because they know there's a huge market for it and lots of people want them. Lots of people are going to their doctor and said, I want to lose another 20 pounds, 20, 30 pounds. They're expensive. So if everyone tries to get on these and every pharmaceutical company puts one out there, the healthcare cost is going to go way up. And so I tend to ask people to, not in the office. In the office, I take care of the patient, but we're having these conversations. I want people to think about, how did we get there? And we got there by, eating crappy food. Or, crappy food sometimes tastes good. I'm not speaking against that. I'm just saying too much crappy food. I mean, and the other way we've got there is we drive to the crappy food instead of we walk to the crappy food, right? Or we call Grubhub and have them deliver the crappy food without talking to anyone, going nowhere, doing absolutely nothing. And then the one that really kills me is when people start getting their food in smoothies, because the last thing that we've done, delivered a smoothie to you and it's crappy, all sugary and whatever. And then the last thing that we've taken away from that exercise is this chewing. Chewing was the last muscle strength thing you were doing with the crappy food. And now you just suck on it. And then we wonder why we're getting obese and our diabetes is going up. And, so I said to people, before you think about giving this injection, it's going to cost you $15,000 a year and your insurance will pay for it, sure. But trust me, we're all going to pay for it in the back of the door. Let's go back and think about, how do we get there and where can we make some changes that would favor that you don't need that or not need too much of it, if you will. So. Mm-hmm.
Well, being on mid long term and stuff, they've been people coming out with like paralysis in their stomach and things like that.
Yeah, the long-term effect, I think we're going to learn that there are plenty. We don't know them all yet because they're very new. And there's a lot of anecdotal stuff. There's a lot of people coming out and saying, now I have this, now I have that. And it'll take some time to weed through that. There's always some of that is real and some of that it's real to that person, but doesn't necessarily mean it's real to the entire population. And that takes time to weed out from the studies and the data collection and whatnot. I think what we don't know, which is the next big problem on this, is we don't know when to stop them. So like, when do you stop? Like now you lost 30 pounds. What do you do now? Do I just stop the medicine and see what happens? Do I just stay on it for life? It's like, okay. A life. I mean, it is a medication treatment for some people. It is a lifestyle change for some people. And I'm not undermining obesity. Obesity is a real problem. It's bothersome not only physically, but it's also bothersome personally and emotionally. So I'm not minimizing that. I'm not saying that we don't need to take care of that. But it's the end point. Like, when do we stop and when do we go back? How do you, if you stop the medicine, what else did you do so you don't need to continue the medicine? And are we spending enough time preparing ourselves for that, to how to come off these medicines? So I think there's a lot of open questions with them, but that's an example of medicine where there may be some shortage They may be very expensive. Your insurance may not pay very much. So I was just in Puerto Rico. My father's been having some health issues, and so I went to buy one of his medicines. And the first time they went to buy, my family went to buy, it said the insurance doesn't cover it. So I went to the pharmacy in this trip and tried to figure out some more about it. And then the pharmacist said, "Oh no, the insurance now is covering it." You say, "Okay, well, that's great. You know, what's my copay?" "Well, you have to still pay $800 for 30 days. They said, "Well, how much are they covering?" "They're covering $37. So they no longer refusing it, which because they knew that we were going to appeal for it and all that. And then they will lose the appeal when the doctor writes a loan letter. And so now what they do down there is they pay $30 for an $800 medicine. And now you got $770 left. So the good news out of the story is after 20 minutes of talking to the pharmacist, we found a coupon and this and that. I only paid $285 for the medicine instead of $700 for it. So coverage is always a challenge, and it depends where you are, what insurance you have. So it's a difficult question to give a straight answer.
And it happens in Puerto Rico as well.
And it happens in Puerto Rico just like anyone. Never
I knew you were coming, so I got questions.
please go ahead. Yeah. Okay. No. No what? No. Yeah. So why don't we take one more of yours, and if you guys have some written questions, we'll take one of you. Okay. No, go ahead.
I saw the largest human being that I've seen last week. He was a greeter at one of the stores. And then he was on break when I was leaving, and he could hardly move. What the? He was 32 years old. What's the hope for a person like that? How could he ever get that?
Yeah, it's hard to talk about somebody I don't know and a situation that I don't understand or see or know. But there are some, especially younger people who have endocrinological conditions, which are either genetics and or problems with hormonal changes and other things like that, which makes it very difficult, if not impossible, to just change what you eat and lose weight. And so there's some people who have true medical conditions, some of them which are treatable, some of them which are, we don't really know any better how to treat. So again, it's hard to just look at somebody and make an assessment and a judgment about. So and the reason I say this, what I'm going to say now, is because when you look at historically and you look across countries, you'll see the difference. The majority there, it's hard to quantitate the number, but a large number, let me just say, of Americans who have obesity is more attributed to our lifestyle than it is to medical conditions. But that's not to say that many of the people with lifestyle also have medical conditions. So if anything, I would encourage you, try not to assume that by the way somebody looks, we already know what's happening to them. Because the reality, even in my office, when I'm working with them over months and years with other doctors helping, we still sometimes can't figure it out, despite doing all the right things, if you will. So it is a difficult thing to treat sometimes. But the reality of the world now, the world way, is that the American population is getting more and more and more obese out of proportion to everyone else, or most other people in the world. And they're people that live in countries where they're not obese, they come to the United States and then they get obese. And so why is that? Is it the food? Is it the stress? Is it the pollution? Is it the microplastics? Again, there's this missing components that we don't understand yet. But the reality is that people do become generational. I think at a prior presentation I made here, somebody shared how their family, when they at back home, wherever they were, whatever home was, they were lean and slender, and then they move, and then within years of living here, they all got obese, and then they will go back and they'll lose the weight, and they come back and they gain it up. So some concept that the coming and the going to in and out of the United States change their weight. So there's clearly a lot of factors into that equation, and sometimes it's hard to kind of figure it out. The new medicines help through affecting the way you eat. That's how they affect you. They tend to reduce the amount of food you eat. And so, and they're fairly effective. Not everyone loses weight with them though. And there's some people who take them, feel bad, and can't lose any weight with them. So it's not an explanation for everyone, but there's a large majority or a large number, I should say, in the United States, which is dependent on the kind of food, the quantity of food, and the other things we're not doing for food, you know, like planting and walking, chewing, and, you know, doing those kinds of things. So,
You have to give the guy credit for being out in the world and having a job.
I get it. It made me
yeah.
overwhelmed with compassion for the man.
Yeah. And, you know, obesity is a cause of death. It does take some people's life. It's a real medical problem.
It's gonna take a big toll on him.
Sharon was pricing scales in here the other day and she remarked that, you know, I used to recommend this scale a lot and because it was really big and it went up to 600 pounds. And I see now that it goes up to 700 pounds.
Wow.
Pretty sad.
Yeah. I think there were some questions here. Yeah. Javier Lopez, nice to meet you.
I'm a retired X-ray tech, 20-something years.
Okay.
I'm back there, it said Oscar exclamation. And I was showing him, because he always complains about pain in the right side of his spine, probably, you know, from computer or how he gets his phone. But I just wanted to speak about bone health, spinal health. Because he does toll on your bone. Me when I was at 220, I feel my ankles giving out when I just stand in the kitchen. But he said only pick the ones that are important so we don't look dumb. So can you tell me which ones you want to talk about? I just made a quick list, you know, about, you know, I heard you talk about healthcare benefits, coverages, and then whether it's smart to join AARP, because they've been sending me that stuff since I turned a certain age and I haven't joined. But when I went to driving safety class for 10 years, they gave us a discount. We were supposed to be AARP, but I told them I didn't sign up yet. Should I sign up for AARP? And the dental plans we need to talk about. Anyone who you want to pick, let me know. But they agree for wellness. I mentioned after medication, do's and don'ts. Low vision clinic for all of us who have vision issues, because it's really good about getting people to get out and out if they have problems with their vision.
All right, let's stop because I'm starting to lose the first one and the second one I want to talk about. That's great. You're giving plenty to talk about until 4 p.m. So let me say something about bone and health. So it's really interesting the effect of body size on your bones. And I'll make the distinction of bones and joints. So there's joint problems, and then there is long bones, if you will, problems. So if your weight is higher than, let's say, the lean weight, whatever that is for your body size, your joints tend to hurt more because they have that extra work to do. But the bones tend to mineralize better because the bones mineralize, meaning they retain your calcium, which is what retains their strength, by actually doing resistance work against it. So if you have a slightly higher weight, you're actually carrying more around. That means your bones actually seeing a little more resistant. So if you're a really, really thin person, you may be more prone to having osteoporosis, which is the lack of calcium on the bones, which can break down. Now, it's also proportional to your vitamin D, which is proportional to your skin color, which is also proportional to your sun exposure. So it's not just your size or your weight. I'm just focusing on that at the second. There are other things in that equation. But so maybe be a little heavier favors having more bone mineralization, but it would also favor more joint problems, if you will. So it's the balance there. And we see this all the time in rehab. People lose a little bit of weight and suddenly their joints get so much better. Now, we all think it's the weight. I personally think it's the inflammation. There's a systemic inflammation, good health, good nutrition, good exercise, all reduces inflammation. Your joints feel better. It's not just that you lost 7 pounds or 6 pounds, because sometimes the relief is much greater than the actual weight loss. I think it's the inflammation reduction that actually makes everything else feel better. So yeah, synovial fluid, right, exactly. The lack of inflammation, the dryness, there's some component of dryness in there. So So yeah, do not underestimate the importance of your skeleton in there and evaluating. So having your calcium, bone calcium checks, it's important as we age and taking action on that to protect you from fractures and also the joints, protecting the joints. You were going to say something.
Well, like, if someone gain like density or like thickness.
Yeah, and well, you gain weight and don't move. No, it doesn't. You got to move. You got to actually move the weight around. So it's the force or the resistant exercise about the weight. But you don't have to gain weight to that. You just do some bands and then you get the resistance. Don't need to gain the weight, you know. So I'm going to claim ignorance on that one. So I'm not sure. I could say things, opinionated things without knowledge, and I don't want to do that. So, yes.
He was more talking about spinal health because he had trouble with the C-spine, posture correction.
Yeah.
Keeping from making it worse because you see some people really cut
Mhm.
back. Some people just find seem to collapse. And you want to
You know,
activate
Dr.
Right.
Lopez, as I'm growing older, I feel like the skeleton is changing,
Yep.
particularly my head. I feel that I'm kind of hunching forward, my head is coming through. And what that does is this weight creates a momentum that wants to turn. And to resist that, the muscles in my neck must work.
Mhm.
The other thing that I realized, and I don't know if it's connected or not, is that the more this shape of head falling down, the more acute it becomes, the more I feel that I'm losing my balance.
Mhm.
So now it's not just a neck pain,
Mhm.
it's my balance.
Mhm.
My balance affects my walking.
Mhm.
My walking increases the chances of me falling down.
Mhm.
So it's a chain
It's all
reaction.
connected. Yeah.
So I guess my question is this, what do we do to keep that skeleton healthy?
Yeah. No, I think we need to bring the physical therapist more often here.
Me more.
That's right. There you go. So, I mean, that's the key. The key is, you know, it's nutrition, is posture, is exercise, but proper exercise. So as you get older, you lose muscle mass. It's part of aging. Some people are trying to change that until we get the right answer for that. That's what happens. And so you have to work harder to retain the muscle you got. So if you're working the same that you did 10 years ago, you're losing the battle. You actually got to work harder to retain the muscle you had. You need to retain the muscle you had to retain your posture and your strength. So yeah, that means you got to work out more as you get older if you want to retain health. And so it's a general statement. It's not a very specific statement, but what does that mean to you? That's a conversation with a physical therapist or an exercise physiologist, who Linda is one. So again, that's what she means, hang out with her. And I know that there are a number of activities in this program that are intended to work with your gait, your balance, and other resistant exercise. All of these count. All of them are important. I want to make a comment about falling and balance. So some of that is your legs and your brain. Some of it is your eyes. And I think it's going to get back to the vision. So I haven't read the study, but I just saw some headlines on the impact of hearing and eyesight on dementia. And apparently 20 or 30% of symptoms of dementia could be attributed to just short eyesight or problems with the vision, problems with hearing. We get a little more confused where we are if we don't hear and see where we are. We can fall down more easily if you don't hear and see where we are. You know, things can happen that we don't know are happening because we can't hear it or see it. And suddenly we like out of place and, you know, can't find things because we don't quite see where we put them. You know, so hearing and seeing have a huge amount, 20 to 30% is huge impact on this one thing called dementia that we're also fearful of. So think about your hearing, think about correcting your hearing, think about getting your eyes examined, correcting your eyesight, as well as the posture and the balance and the physical exercise to maintain the core. So So part of what keeps your posture is the core exercises, which balance your back and front muscles to keep posture. And so all that takes effort. You need to plan for that. It doesn't just, just walking doesn't just do that for you. Walking keeps you healthy a little bit. You got all these other things that need attention. And this is where a program like this, where you got access to multiple presenters and people that can help you build different kinds of exercises for different things, and you can rotate them around. That's the best thing for your body. You rotate your physical activity. So you're not always doing this and not that. You do a little bit of this now, and then season changes. Now you do some of that, and the season changes again. You do some of this again. And, you swim in the summer, you bike in the winter, you do change around the physical activity just so you can kind of constantly be training your body to be remodeling itself, if you will. And that tends to favor the healthiness of the body. Did that help? Yeah. You got one more, and then I got to start driving because they're expecting me in Davis at 1:15. Is there anybody at home with a question? No? Okay. So then you get another round.
Okay. Is there anything that says there's a connection between migraine headache and anything else that's going on in your body besides the stress?
It's a general question, so I have to be careful how I answer. So the first comment I'll make is not all migraines are created equal. So not everyone who has headaches have actually migraines on the pure definition of what a migraine headache is. So the pure definition of a migraine headache is a vascular event, usually veins or something in the brain. They change, they spastic, they open and close, and that triggers a discomfort. It could be triggered with things like lighting and noise and things like that. Not everyone who has a headache with light bothering them actually has a migraine. So it's hard to say that any one thing will help everyone. So it's important to get a diagnosis first to make sure that you have the kind of headache that is a migraine. I have a patient who had a headache for 1.5 years. That was terrible migraine. She was on narcotics and all that. And finally, somebody decided to investigate her sinuses. And the ENT went in there, drained her sinuses. She got off of every drug. She's the happiest woman I've ever known. For 1.5 years, she was down on the border of depression, suicide, of pain she had. And everybody was telling her she had migraines, shots for migraines. And it was her sinuses. So sometimes it takes time to figure it out, the right diagnosis or a headache. And so it's hard to say any one thing is going to help people with migraines because migraines get misclassified a lot. So yes.
How does grief affect your health?
Grief?
I didn't hear the question.
How does grief affects your health? Can you qualify grief a little bit better? Loss of loved ones, or loss of a pet, loss of a home, maybe, or something like that. So it can affect your life, your health very much. There's a cardiomyopathy called Takotsubo, which is a Japanese name, and in English we call it a stress cardiomyopathy. It usually happens with stressful events, and one of the most common stressful events is the loss of a loved one. So in fact, there's a group out of Marin County here in California who wrote a paper where they related 250 cases in their hospital over like 5 or 7 years of this condition, and they interview everyone who showed up with this condition. Fire in the back of the house on the hills, death of the spouse in the middle of the night. They wake up to that spouse, fire from work, just told by the boss they're fired. 20 minutes later, they can't breathe. They have this acute cardiomyopathy, stuck in traffic, car accident, so all these really kind of large, kind of intense emotions can actually, in certain people, trigger a cardiomyopathy, meaning you go into acute heart failure, you're in the hospital for a week. No one knows why you're in heart failure, and it's the stress. And it tends to get better, but some people can actually acutely die from it.
Involved even a couple of kids and his wife. died, the teacher.
Mhm.
And as soon as he found out, he had a heart attack and died.
Yeah.
Said it was broken heart syndrome.
That's right. That's the other name that it gets. It's the same. Takotsubo cardiomyopathy is the broken heart syndrome. Yep, that's correct. That's exactly the name, the other lay nerve.
That's
Yeah.
what we dealt with.
Yeah, no, that's very real, very real. We see maybe about 50 or 70 cases of this at UC Davis a year. So it's very real. So, yeah, you're welcome. Yep. All right, I'm gonna wrap it up because I need to be somewhere in 15 minutes. So,
Thank you so much for
but
coming.
thank you for having me. Yeah, you're welcome. No worries.